Hi, this is Unit 14. This is nursing care of the normal newborn. So this is what we're going to do for a normal newborn. So starting out with the normal newborn, let's look at their vital signs. So respiratory rate needs to be between 30 and 60 breaths per minute. That is pretty high. I don't get too worried when I get I breath sounds because that's pretty much normal in a baby. Heart rate 110 to 160. Sometimes I've even seen babies down in the hundreds, and as long as everything else is checking out, they're okay, but 110 to 160 is normal. Temperature 97.7 to 99.5. We obtain all of their temperatures axillary, unless we have a concern that they might be super cold, and then we might do a rectal temperature just to verify, but most of the time they're always going to be axillary. We're going to look at a little bit of their lab values, which is a little bit different than an adult. So the hemoglobin is 14 to 24. Platelets 150 to 300,000. Glucose, this is where it's really different than in an adult. Glucose in an adult, if we got down to 40, we would be really concerned. But in a baby, 45 is kind of like our magic number. So 45 and up, you're good. 45 and low, we're probably going to start treating that. White blood cells can be anywhere from 9 to 30,000, but we're also going to take into consideration what the baby looks like, what they're acting like, and what their temperatures are, and how their feeding is, what their blood sugars are. That can all tell us something about their white blood cells. Bilirubin, this is a big one that we want every baby before they go home. They have to stay 24 hours, and they have to have at least one bilirubin. 24-hour bili should be between 2 and 6, so anything below 6 is what we're going to want to see. Anything that's getting up in the higher levels, we'll talk about pathological and physiological jaundice. But this is physiological jaundice. Just because when babies are born, their livers aren't functioning totally all the way. And so a lot of times they've had extra red blood cells in their body that they don't need now that they're using their own breathing system. So their body just lyses those, and the breakdown of the red blood cells is the bilirubin. So that's just physiological, it's normal. But if it becomes elevated, then it changes to pathological, which is more disease process. So stabilization and transition of our babies. So most of our places have some type of neonatal resuscitation program in place, but anytime the baby's born, that's what's going to happen. As far as an LPN, you would not probably be doing anything like that. That RN would probably be there doing all the resuscitation things. Sometimes the doctors can kind of predict if there's going to be a problem with the baby, so they will ask that there be a NICU nurse in there if they know that it's going to be a challenging delivery, or it's been a really long delivery, or something's going on. So that first 6 to 12 hours is considered our critical transition period. Transition just means the transition from the baby in utero to the outside world. There's a lot of things that need to change. There's a lot of things that have to go into play here. And so we want to watch those babies a little closer for that time frame, just to make sure that they're doing okay. So immediately, as soon as the baby's born, that baby's going to undergo that rapid transition immediately after birth. We're going to have to really watch their temperature, their cardiac, and their respiratory function. Those are the three biggest things that are going to be something that we're going to have to monitor very, very closely. That nursing exam needs to be completed within that first couple hours after life. They need to be listening to their lungs. They need to be looking at their respiratory rate. They need to be looking at are they struggling to breathe? Do they have any nasal flaring? What is their temperature? Do they have a murmur? What's going on with them that could indicate that there could be a problem? We do want those moms to start breastfeeding or bottle feeding right at birth, just to make sure that the babies don't have any type of hypoglycemic event. They're going to get all their medications, so they're going to get 3 medications. We're going to make sure that they're bonding with their moms. So immediately after birth, if it's a vaginal delivery, they get what they call the golden hour, or we like to have the golden hour, where that first hour is spent with just the mom and dad, just that very important bonding. That's when they will try to breastfeed for the first time, see their baby. We usually don't put any drops in their eyes until after that hour, so at least they can see and look at their baby, and the baby can look at them. And then also maintain that safety of that newborn. Make sure that the baby has all of its transmitters on, all of its things on. Make sure footprints are done. Make sure all of those identification bracelets are placed on everybody. So how do we support that cardiovascular and respiratory during transition? Well, to make sure we're doing it before delivery, we're going to make sure we have everything available for a resuscitation just in case we need it. All the equipment needs to be plugged in, it needs to be attached, it needs to be tried, it needs to be ready to go. Then we're going to make sure we have all the we're going to do the necessary assessment, provide any necessary care that needs to be given to that baby. If the baby doesn't respond to what we're wanting them to do, then we're going to have to take extra steps to make sure that that baby is doing okay. So respiratory is going to be our biggest thing. We're going to look at their respirations. If they don't have good respirations, we have to intervene. If their heart is not beating, we have to intervene. Those are life things that we have to do. The next thing after respirations is probably going to be maintaining that thermal regulations. Babies have no way of regulating their temperature. They don't know how to do it yet. Their brains are very immature. Their neurological system's very immature. They really don't know how to do it yet. So if they get cold, they start to break down all of the sugar that they have in their body. Once they've reached all the sugar, then they start breaking down their brown fat, which we do not want them to do. And they start using that for energy, which is not what we want them to do. So what can we do to prevent them from being overly cold? Well, one is just making sure that we have an ideal temperature in the room, or make sure the baby is not wet. If the baby's wet, it's gonna release its heat. If we set them on a cold surface, they're gonna release their heat. If we have a fan blowing on them, they're gonna release their heat. So the best thing to do is that kangaroo care right after birth and give it to mom. Mom will maintain that baby's temperature. So we don't want to have hypothermia and we don't want to have hyperthermia. Either way, both of the hypothermia is what we see the most, but either way, these babies can have hypoglycemia. They can go into like hypotension, they can get very dehydrated. So we want to make sure that none of those things occur. So we're going to keep that baby warm. Make sure we keep that temperature up, keep them in a warm environment, keep them swaddled if we're not doing kangaroo care. Preventing from injury from hypoglycemia. If a baby's blood sugar drops too low, they will have a seizure because it's neurologically the brain has to have glucose in order to operate. If the brain doesn't get glucose, it kind of goes into those seizure events. So prevention of hypoglycemia is going to be our best bet. So we're going to make sure that baby's eating. We're going to make sure they're frequently eating. We're going to make sure they're getting things. If we are in doubt, you can do a heel stick and check their blood glucose. So if it's less than 45, we're going to need to intervene. So if you've got a breastfed baby that's not really taking the breast very well and they've got a low blood sugar, we're probably going to have to supplement with some formula, or we'll have to give them some glucose or something to get that blood sugar up. If you have a mom that comes in and maybe it's a large for gestational age, mom has diabetes, mom has preeclampsia, we may go ahead and just do a heel stick an hour after they're born just to double check their glucose levels, just to make sure we're good. If for whatever reason the baby cannot eat, so the baby's very lethargic, the baby just can't eat, maybe it can't suck, it can't get the nutrients that it needs, sometimes we'll have to do what we call gavage. Remember gavage and lavage. Gavage means to give, lavage means to clean, so G and G. So gavage, we're going to put a little tube down and we're going to give them some formula through that tube. Or we can start an IV and we can give them glucose by that. Sometimes we can actually put it underneath their tongue and it is absorbed very rapidly and it gets in there that way too. So there's multiple different ways that we can give that glucose. So how do we do a glucose? Well, we're going to do a heel stick. So a lot of times we're going to go on the sides of the heels. That's where the little capillaries are. Sometimes baby circulation isn't real good because they've just come out. Sometimes they can have like mottling of their feet, or they can have some acrocyanosis. So you could go get some little warm packs, wrap them around their foot for a few minutes before we do the heel stick to make sure we got good blood flow to that leg so we can get a good blood sugar monitor reading. So that's something that we can do. Now, how do we prevent infection? Well, babies have the ability to get what we call ophthalmia neonatorium. It's just an infection in the eyes from all of the bacteria coming through the birth canal. So every baby gets this. It's either erythromycin, silver nitrate, whatever that the facility policy has, but they will get prevention for the eyes as soon as they're born within an hour. We usually give this as soon as they're born. We give the vitamin K, and we also give their hepatitis B. We give them all at the same time, the first hour of life. So they will get that, and that will help prevent any infection. The other source of infection for a baby is the umbilical cord. So we want to make sure we're doing careful hand washing, strict aseptic techniques, make sure a lot of times before the baby goes with mom, a lot of times the doctor will pre-treat it with some type of antibiotic ointment on it as soon as they cut the cord. Now, once the cord's been cut, we tell parents not to put anything on it. Just keep it clean and dry. Don't put any antibiotic ointment on it. Don't put alcohol on it. Don't do anything on it. Just leave it alone. The cord clamp will usually stay on that first 24 to 48 hours. It will go off, it will come off before they go home. But we usually tell parents to monitor it for any redness, swelling, any drainage, anything like that would be an abnormal thing. We tell moms and dads do not put them down in a tub of water until the cord is completely fell off. Usually that's 10 to 14 days. Okay, now potential for hemorrhage. Because babies are early and our bodies need E. coli in order to manufacture clotting factors. We've got to have we need E. coli to manufacture or synthesize vitamin K. Vitamin K helps with clotting. So babies they don't have any E. coli yet because they're brand new. They don't have any bacteria cultures in their colon yet. So they don't have that vitamin K ability to help clot. So if they don't have that, we give every baby that vitamin K shot. So they will get phenodoinodoin. They will get 0.5 to 1 milligram, depending on what the doctor wants to give, of vitamin K. If they do not get this, if a parent would refuse to get the vitamin K and it's a little boy, he cannot get his circumcision till a week after because they have to wait till that colon starts to produce the E. coli and it gets in there and the vitamin K starts to be produced. Another place for hemorrhage that can happen is if the clamp comes off too soon and the blood is still there, it can come out and bleed. So we want to make sure that our cords are properly put on. So make sure that you inspect every time you look at your baby. Make sure that you inspect that umbilical cord and make sure everything is okay. Preventing any misidentification. So obviously we do not want to switch babies up with anybody. So that's a difficult thing. So most facilities will have policies and procedures in place. Most of the OB units are locked. You have to buzz in to get in. Everyone should have a name tag that works there. If they do not have a name tag, people should ask them who they are and what they're doing there with their baby. Before anybody takes a baby out of a room, I would make sure that it is the nurse, the appropriate nurse, make sure that it's who they are. Always, if you bring a baby back, you always have to check the numbers of the mom's band to the baby's band. If you're giving it to the father, check the father's band or significant other's band. They usually will have some type of an alarm on them, and that alarm will go off if somebody tries to tamper with it, if it gets too close to a door or a window, anything like that, these will go off. Footprints really aren't going to do anything. They're more of something that mom will like more than actually preventing an abduction. So just make sure those things are in place. Other things, we've kind of talked about that, but just general care, just make sure you're looking at the cardiac and respiratory status. Make sure you're keeping the baby warm. Babies need to void within 24 hours. They need to be eating, and they need to have their first meconium within, I think they will give them up to 48 hours for meconium. So good hand hygiene, make sure you're doing good skin care. So those are our major things that we're going to look at with that baby. Cardiac and respiratory, temperature, are they eating, are they peeing, are they pooping? Those are the biggest things. If they don't urinate within 24 hours, we're going to have to do some type of testing. We did have a baby that didn't have a stool, and they ended up having a blockage and had to go to St. Louis. So that can happen. So we just want to make sure that we're catching all that stuff. Prevent any abduction. Observe the newborn's behavior. Observe mom's behavior. How are they bonding? Observe for any pain in the newborn, and reinforce lots and lots of teaching to mom and family members. So that's kind of what our job is while they're there with us, and they're there a very short time with us. So we got to get a lot of things in while they're there. So that ongoing cardiac and respiratory monitoring, we're going to get vital signs. So the first few hours, they will get vital signs very frequently, just making sure that we're not missing something. Then sometimes they will go to every 4 hours or something, we increase it just to make sure. But babies are at risk for aspiration too. So if you've got a baby and their heart rate's 80, I would be very hesitant to feed that baby, because when they're trying to eat and breathe at the same time, they may suck some of that fluid into their lungs, and we may develop some type of aspirate pneumonia. So if the respiratory rate is over 60 and the baby seems like they might be having a little bit of trouble breathing, I would not be feeding that baby, and I would be trying to figure out what's going on with that baby. Make sure there's a bulb syringe in the bassinet, so make sure there's a bulb syringe. Make sure mom and anybody in the room knows how to use the bulb syringe. Make sure you teach mom that the baby needs to sleep on its back or its side the first year of life. This decreases the risk of SIDS. The American Academy of Pediatrics is kind of like what we use as our guru. They've done multiple tests and studies, and they have found that this works. So we also talk to them about safe sleeping protocols. We do now, which we may get to that, but we talk to them a lot about safe sleeping, like no stuffed animals, no blankets, only the swaddle, no bumper pads, nothing like that, no co-sleeping, nothing like that in the beds. Nutritional intake, just remember, breastfed babies have to feed more often. Milk doesn't come in until about 3 days after birth. So, but the more that the baby sucks, the quicker the breast milk will come in. So we want them to suckle every 2 to 3 hours. Get in the habit of getting that. Babies will metabolize breast milk way quicker than they will formula, so they're going to get more hungry and they're going to need that nutrition quicker. So breastfed babies need to be fed every 2 to 3 hours. They need to be awakened at night every 3 if they're not up. Bottle-fed babies are every 3 to 4, and they need to be waking up in 4 if they're not awake. Observe how moms are feeding them, reinforce any teaching. Look at any difficulties that they're having, maybe sucking. Is their frenulum, that's the tongue at the top and the bottom. If they are tongue-tied or the tongue doesn't come out, that's going to give them difficulties. So we want to always check for that, make sure they're doing that. Make sure they're looking at avoiding bowel movements. We're going to weigh them every day, making sure they haven't lost weight. It's not uncommon for them to lose weight. Usually it's a little bit of a fluid shift and they get a little dehydrated when they're first born. So how do we prevent infection? So preventing infection in our newborns is basically just really good hand hygiene. Making sure you're taking care of their cord, making sure you're wearing gloves, making sure that you're wearing, using the sanitizers. Look at mom's history. Go back and look at her history. Did she have group B strep? Was those membranes ruptured for a long period of time? Did mom have a maternal infection? Because sometimes the same nurse is not going to be taking care of them postpartum that did in labor. So the labor nurse knew that she had group B. The labor nurse treated her for infection. But the postpartum nurse should be told that, but if they're not, it's kind of up to you to go back and look. Did they have group B? Do I need to be monitoring that baby a little closer for infection? Do I need to be taking the temperatures a little bit closer? Do I need to be watching their respiratory status and their feeding patterns? So always look at the umbilical cord. We've talked about what to look for there. Early signs of sepsis. So if you get a baby that comes in and maybe mom had premature rupture membranes for 3 days, and all of a sudden baby's got poor feeding, their sugars are low, they're irritable, they're lethargic, and they're having long periods of apnea, those are all signs that baby could be developing sepsis. So we would want to be really investigating that and getting something done very quickly. Don't share anything between newborns. Anything that comes into the newborn's room needs to be cleaned, and then it needs to be cleaned again with the proper antiseptic solution when it comes out. So if you use reusable equipment, it needs to be wiped down between every baby that is using this. Make sure you have clean blankets. Make sure you have clean stuff that you're using with everybody. Use universal precautions. We have to wear gloves until babies had their first bath. They have all of that amniotic fluid. They have all the other stuff on them. So until they've had their first bath, we have to wear gloves with them to prevent infection to us. As far as skin care, we're going to look at their skin. We're going to look at their skin observations. Sometimes we will delay their bath. We usually will delay their bath until their temperatures are stable. So we usually don't give them a bath for the first 8 hours. We allow all that vernix, we allow their bodies to try to, regulate everything. And with it, if 8 hours and their temperature stable at 97.7 or greater, 97.8 or greater, we can give them a bath. If they're struggling with their temperature and they've had a hard time keeping it up, I would not give them a bath. We usually give them a sponge bath until the cords fall off, until it falls off. Wash off any traces of blood to minimize any kind of transmission of infection. We usually wash their hair, and I usually take a brush and I kind of scrub in their hair to get all those amniotic particles off there and everything. Sometimes we just allow that vernix to wear off. You can't hardly get it off, even though you're scrubbing and scrubbing, you can't hardly get the vernix off. So we just allow that to wear off naturally. We usually encourage our parents to help with the bathing if they want to. They can bathe them if they want to, whatever they want to do. So again, we've already talked about axillary temperatures. So dress the newborn the way that you would dress. If you have a newborn that is cold, you're going to dress them warmer. If you have a newborn that's warm, we're going to dress them cooler. If you're cool in the room, they're cool. If you're warm, they're probably warm. But really all they need is a swaddle, and then if they're cool, we can put a blanket over the top. If they still remain cool and you don't want to put too many blankets because it's interfering with maybe their breathing, we would put them under a radiant warmer. And so to put them under the radiant warmer, we would put a little thing on their belly and set the warmer to what it needs to be, and it'll keep their body at that temperature. There's no special ointments or anything that go on their skin. We don't put any lotions, anything like that. We use a mild soap and water to give them a bath. We don't use any talcum powders. We make sure the cord is uncovered. We roll down the diaper to make sure that it's not covered. We've already talked about abduction. Just make sure that you are aware of those kinds of things. And this is another one that they're looking at. All babies cannot be unattended. So if you have a mom that wants to go out and smoke and she goes, I'm just going to leave the baby in the room, they can't do that. The baby has to come to the nurse's station. If the nurse has to leave the nurse's station, the baby has to go to special care nursery. So they can't just leave their babies. Someone has to be monitoring that baby at all times. Okay, we've kind of already talked about all of these things, but just go back and look at your your abductions and things like that. So, what is a newborn's behavioral responses? Well, your babies are going to respond to the environment in a pretty predictable and organized way if we anticipate what they need. If we're anticipating, yep, their sugar looks like they're low, we anticipate that and we get that need met, the babies are going to react the way we think they will. If the babies are hungry and we start noticing those cues where they're, sucking on their hands and we feed them before they cry, we start to anticipate their needs and they become easier to deal with. So psychosocial tasks in an infant is the sense of trust versus mistrust. So if that mom is starting to recognize cues and, baby's diaper is wet and before the baby cries, mom is changing the diaper. Baby's starting to fuss and mom recognizes that the baby just wants a pacifier. That is developing trust in that baby, that when that baby has something or needs something, that mom is going to be providing that for that baby. Kangaroo, all of these swaddling, non-nutritive sucking is just the pacifier. A lot of people mistake sucking, they're hungry. They're not necessarily hungry. Sometimes babies just want to suck. It helps soothe them. It provides comfort for them. So sometimes we just encourage that non-nutritive sucking just to keep them, it gives them something to do and it helps comfort those babies. If a baby is very inconsolable and they're very crying, sometimes we will just kind of strip them down, put them up against their moms, and sometimes that's enough to kind of meet those needs. We try to meet their needs before the baby gets upset. So we start to look for those cues and try to look at their behavior responses. Pain in a newborn. If you have a newborn that has pain and it's prolonged and we can't get it under control, that can actually change those neural synapses and things in the brain and actually cause more problems as they get older. So we really want to make sure we catch that pain early on. We are seeing some babies now that are having some pain with neonatal abstinence syndrome where the babies are exposed to methamphetamines or they're exposed to fentanyl or heroin or things like that, and they're coming out with lots of pain, and we're having to medicate them with like morphine every 3 hours to keep them comfortable. But they can experience pain and discomfort. So we do a pain scale on them every time we assess our babies. We look for excessive crying. We look at facial expressions, their body movements, changes in heart or respiratory rate, oxygen saturation. How are they tolerating, everything. It is our ethical responsibility to prevent and treat any pain in our babies that we see. So it's important that we make sure that we do those kinds of things. Also promote a very quiet, soothing environment. If you get, sometimes you will go into the room and there'll be like 50 people in that room. Is that a quiet, soothing environment? No. So a lot of times we'll, ask just 2 people to come in the room at a time, turn the lights down, lower the temperature, wrap the baby so the baby doesn't have that sense of overwhelmingness with everyone there. So how do we get a baby ready for discharge? Well, at Carbondale, we have a big discharge protocol that we have to do before they can go home. So we have a protocol that we're going to go talk to mom. We're going to make sure we cover all of this information, but we're going to monitor and promote health adaptation to the newborn life. So we want to make, how can we help mom learn to know her baby and help her and the baby adapt outside of utero. Help other people adapt, siblings, significant others. We're going to look for that poor bonding. Are they not wanting to change the diaper? Do they not want to feed the baby? Do they want the baby at the nurse's station all the time? Prevent pain. What can we do to prevent any type of pain that we can do? Kind of establish where the parent's knowledge level is. What do they know? What do they not know? What do they need to know? So, kind of establish where they at as far as education. Every baby's going to be a little bit different. So we need to kind of answer as many questions as we can. Ask them, what questions do you have? Sometimes they don't really know what kind of questions they know because they don't know what they don't know. And so we have to kind of ask them, do you know this? Do you know that? Well, let me explain that. And we have 24 hours to do it. Actually, 24 hours after they're born to literally poke in as much information as we can. And you and I know I'm trying to poke this information into your brain right now, and you probably lost me 10 minutes ago. So, we got to come full circle again and reiterate what we're trying to make sense of or what we're trying to make sure that they understand. So circumcisions, there's no medical reason that a baby has to be circumcised. Current evidence indicates that there's a health benefit for babies to get circumcised, and it outweighs the risk. With babies that are not circumcised, there's actually more risk for urinary tract infections because sometimes bacteria can harbor in that foreskin. So that's something that they talk about, and this actually came from the American Academy of Pediatrics. So if you have a family member ask you about it, you can quote what the American Academy of Pediatrics says. That the circumcision the benefits of the circumcision outweigh the risks. So, but some parents don't want to do it, and that's okay. There's a trend heading that direction, so that's okay if they don't want to do it. It is contraindicated on any babies that are in transition. So that first 8 to 12 hours, we will not do a circumcision because we're still monitoring for extrauterine life and any problems. If the baby's preterm or they're sick, if they have a family history of a bleeding disorder, if they refuse the vitamin K injection, if they have epispadias or hypospadias where the urinary outlet is on top of the penis or below, we would not do a circumcision. Parents need to be given enough information and enough time to make an informed decision. They have to sign a consent for this to be able to be done. Make sure that we're thinking about their culture. What does their culture play in this? What do they want done? So how do we get them ready? We have something called a papoose board, and we kind of strap them down. A lot of times they'll give them a little bit of sugar water. It helps comfort them. We swaddle their arms and makes them feel more comfortable. Some of the doctors will actually give them a little bit of lidocaine to kind of numb the area. Some do not, it just depends on the physician. And there's different techniques that we can order. Sometimes Some doctors will order some pain medication. Most of them do not. But you can have a Gomco method and you can have a Plastabel method. So there's a couple different methods of circumcision. This one is a Gomco, and this is your Gomco here, where we like cut everything off here. This is your Plastabel, sorry, where this little plastic piece goes over the tip of the penis, and then they tie a really tight knot. They cut the foreskin off. This Plastabel will just fall off. This is your Gomco, where it's a little machine that goes in and like trims it off. So they're all a little bit different. Just know which type you had, because the Gomco, you always want to keep Vaseline, like lots of Vaseline on it. You don't want it to stick to the diaper. The Plastabel, rarely is there any bleeding with the Plastabel, but there can be, and we don't use any Vaseline for that one. We just keep the diaper on very loose so it doesn't stick, and we just monitor for any types of bleeding and let the parents know to keep it clean, dry. There will be a little bit of yellow crust that comes on there, but we want to leave that. Don't tell them not to pick that off. Don't submerge them in water until the Plastabels fell off. So those are just a few things that we would make sure that they do, those type of things. We talked about all that. Okay, so we did talk about this already. Keep it clean. Don't use any Vaseline if it's Plastabel, but you will use Vaseline if it's the Gomco. No bathtub, loose-fitting diaper. We kind of talked about all that. Immunizations. Hepatitis B will be given at birth. If mom is hepatitis B, the baby will also be given a hepatitis B antibody. And they will be given their HBV. So they're going to get the eye ointment, they're going to get the hepatitis, and they're going to get the vitamin K. And make sure they follow up with their vaccines. The hepatitis B is initial, and then 3 months, and then 6 months after the first. So again, if mom is hepatitis B, the baby will get a hepatitis B immunoglobulin, or like an antibody immunoglobulin, within 12 hours of birth to help prevent the baby from getting the hepatitis B. Neonatal screening, every baby will be screened before they leave the hospital. We have these 5 little dots. All these dots have to have blood on them. They're testing for multiple different metabolic disorders. So these are just a few of the disorders that they're testing for. If anything comes back abnormal, your pediatrician will be notified, and then you will be told what to do, and it'll probably be repeated. And if it still comes back abnormal, then you will be referred to the proper healthcare provider that you need to be given to according to what your baby came in with. So hearing screen, every baby will get a hearing screen. The hearing screen, we just put these on. It's basically electrodes. It gives like these emissions, these sound waves, and it allows us to know if the baby has any sensory neural hearing loss. Sensory neural hearing loss is something that's really difficult to treat. A lot of times it's can't be treated as well. Sometimes they fail it because they've got like a lot of cerumen buildup in the ears. They've got a lot of amniotic fluid. But if they fail the second one, we will send them to St. Louis for an evaluation. So make sure you're giving lots of information to your parents. So give them lots of information on feeding. Make sure you're talking to them about, when they need to be sleeping, crying, what kind of sensory input that they need, health maintenance. So feeding, breast babies every 2 to 3 hours, bottle feeding every 3 to 4 hours. Bottle feed babies need to be burped. Bottles, once the baby has sucked on them, they're only good for an hour. So even if the baby only took 3 sips and it's been over an hour, they have to throw that bottle away. Same thing with breast babies. Breast milk is good in the refrigerator for 24 hours. I think bottle is good for 24 hours in the refrigerator. So just make sure you're giving them all of those things. Sleeping. Babies are going to sleep a lot. It's normal for them to sleep a lot. It's normal for them to kind of jerk in their sleep. Crying is normal. Babies will cry if their diapers are wet, if they're hungry, if they're emotionally overstimulated. If you take the baby home and they've had company, sometimes by 4 o'clock they're just screaming and there's nothing you can do. They're overstimulated. So the best thing to do is take them into a quiet room, swaddle them, maybe just pat them and help with that kind of thing. Health maintenance, make sure that you're getting them to their doctor. They need to go to the doctor that first week that they're born to make sure that their weight is stabilizing. Then they will go back in 2 weeks. Then they will go back in a month. And that's just because the doctor's wanting to keep an eye on that baby and make sure that they're growing like they need to. So there are classes that moms can take. Sometimes it's better if they took them before they had the baby, but there's parenting classes. There's, birthing technique classes, sibling classes, all these different kinds of classes that they can do. So it's good if you can have moms demonstrate to you. It's easy for us to teach them, but we don't know if they learned unless they demonstrate to us. Learn one, see one, do one. That's how you learn. You learn by being taught, you learn by seeing it being done, and then you learn by doing it yourself. Sometimes it's scary to do it, and sometimes you're going to find your parents are going to be a little scared, but they will learn by doing the activities. Handling the newborns, just make sure that they know to hold the head. Make sure the head has to be held at all times. They don't have a lot of muscle control in their heads. So how do we clear the airway? That's going to be your bulb suction. Show the parents how to use the bulb suction. Getting inside the mouth and sucking that out. Sneezing is normal. It just means that they're trying to clear their airway. So that's normal. Now, if they get yellow or green nasal drainage, let them know that they probably need to call their healthcare provider and have them take a look at the baby. If the baby stops breathing or has any breathing difficulty that the parents are worried about, they need to call 911 and seek emergency care, especially if the baby stops breathing for more than 20 seconds. We talked about that periodic breathing. That's normal. It's normal for a baby to kind of stop breathing for about 5 seconds, but more than 5 seconds, 5 to 10, we're getting out of the normal range, and we need to get that baby looked at. Temperatures. Protect their babies from drafts. So if they take the baby home, make sure they're not putting it in front of a window, make sure there's no fans, make sure that they're dressed appropriately. Axillary temperatures is what you're going to want them to do. If the temperature consistently stays below 97.7 or stays above 99.5, that needs to be reported to their healthcare provider. Stool and urine patterns, they usually will have 6 to 10 wet diapers a day. That's how we know that babies are getting enough fluids and enough foods, especially your breastfed babies. A lot of moms get very concerned. I don't think the baby's eating enough. I don't think I'm producing enough milk. You probably are, but they get concerned about that there's not enough. If that baby's having 6 to 10 wet diapers a day, they're good. Now, if they don't void within a 12-hour period of time, they need to know their healthcare provider, especially if they're home and the baby hasn't been feeling well, maybe the baby hasn't been nursing well, maybe the baby hasn't been taking a bottle well, and you have noticed that it's been 12 hours and they haven't urinated. You need to give the doctor a call. Babies can become dehydrated very, very quickly. Stools in the baby are going to start out meconium, and then depending on what kind of food or formula they're on, they're going to change color. So formula-fed babies are going to have more of a darker brown kind of color, and they're going to have a little bit more of an unpleasant odor. Where breastfed babies is going to be real soft, it's going to be less formed, it's going to have kind of a sweetish odor, kind of looks seedy a little bit. Those things are normal. Breastfed babies rarely will get constipated because the breast milk has a natural laxative in it that helps them stay kind of looser. Just because a baby strains to go to the bathroom doesn't always mean that they're constipated. A lot of parents are like, oh, they're straining to go, I think they're constipated. Doesn't necessarily mean that. But if you get a baby that's having diarrhea, every stool is watery, like liquid, and you're changing their diaper very, very frequently. That could be a sign of dehydration. So we would want to look. Babies aren't going to produce tears until about 3 months. So no tears is not going to give you a good indicator because they're not going to have any. But look at the fontanelle. Is their fontanelle sunken in the top? That's a sign of dehydration. Do they look kind of sunken? What is their skin turgor? All those are things you want to look for with your babies. Irritability. Maintaining safety. Once they learn to move around, parents need to be thinking about safety. Never leave the baby unattended on any high surfaces. So if you've got a baby on a changing pad, don't turn your back. Your hand has to stay on them at all times. Never leave them by water. Even if you don't think they can move, they can move. Don't let them around like any kind of plastic things, no pillows, no bumper pads, no blankets, anything like that. Start to learn how to differentiate normal from abnormal newborn observations, or what behaviors that you're looking at, what is normal and what is abnormal. Always use your car seats. Those car seats have to be used all the time. In an infant, it's going to be rear facing. They're going to have a 5-point harness. Always make sure that that top pad is up on their chest area and it's locked in place. Same thing here. We're going to do the nursing process all the time. Assessment. What are we assessing? Subjective and objective data. And then we're going to look at our nursing focus or our diagnosis. So what is our focus? Lack of education, lack of thermoregulation, poor feeding technique, pain. What is the focus? And then what is our goal? What is our P? We're going to add pi. What is our P? What is our plan? What is our goal? What do we want to happen in the end? Then our I is intervention. What are we going to do to make that happen? And did it happen? That's our evaluation. So always remember those, add pi. And that is the end of that chapter.